Hi, my name is Rowena. I'm a fourth-year medical student at Touro University, California, and today I'll be teaching a technique that I learned from my third-year OMT rotation. This is a treatment of the scapula, which is something that my preceptor would do in almost all of our patient encounters. Our typical encounter lasted about 15 to 30 minutes, and after a few days when she taught me the technique, she would have me treat the scapula of almost all our patients while she worked on other parts of the body. And one day I asked her why she did this treatment so much, and in response, she assigned me with homework to look up every single muscle that attaches to the scapula. And that's exactly what I did. And that assignment really gave me a clear understanding of why the scapula is such an important part of the body to treat in terms of its relation to many different parts of the body. So today, before I teach the treatment that my preceptor taught me, I thought it would be really helpful to give that same clinical context and go over every single muscle that attaches to the scapula using this image that I found on Google Images that looks like it was taken from Pearson Education. So to start with the acromion and the scapular spine, both the deltoid and the trapezius attaches here. The deltoid is involved in arm elevation and also involved in the stability of the shoulder joint. And the trapezius, his main job is to really move the scapula and also supports the weight of the arm as it attaches to the rest of the upper body. And the trapezius not only attaches to the scapular spine and acromion, but also attaches to the base of the occiput, the nuchal ligament, and spinous processes of C7 through T12. And so it really expands across a ton of the upper body, all the way up to the cranium. It's not just the deltoid and the trapezius that attach to the scapula. Also, the rotator cuff muscles are attached to it. You have the infraspinatus, the supraspinatus, which runs across here, and the infraspinatus, which runs across the infraspinous fossa. You also have the subscapularis and the teres minor. And of course, the rotator cuff muscles are involved with movement of the shoulder and also provide a really important stabilizing role as well. Going down this medial border of the scapula, you have the levator scapula, which elevates the scapula and actually inserts into the neck. You have rhomboid minor and rhomboid major. These actually connect to the thoracic spine and function to retract the scapula. And you also have the serratus anterior, which attaches to ribs 1 through 8 and inserts onto the medial border of the scapula, and this is involved in protraction. So here, in addition to the attachments that we've talked about with previous muscles, there are muscles that attach to the scapula that also are involved with rib movement. Moving down to the inferior angle of the scapula, teres minor attaches here, and a small part of Latissimus Dorsi attaches to this inferior angle. And very similar to the trapezius, the Latissimus Dorsi covers a really large portion of the upper body and actually inserts onto the iliac crest as well as the thoracolumbar fascia. So you're seeing that, again, that this scapula serves as an attachment point for muscles that attach to many other regions of the body. Moving on to the lateral border, you have teres major and teres minor, which I already spoke about, and the subscapularis muscle as well. And then the coracoid process serves as an attachment for pec minor, the coracobrachialis, which attaches to the which is involved in arm adduction, and also the short head of the biceps attaches here. The supraglenoid tubercle is where the long head of the biceps attaches, and the infraglenoid tubercle is where the long head of the triceps attaches, and these two muscles are involved in arm extension and flexion. And then up here, there's a transverse scapular ligament, which isn't pictured in this photo, but it serves an attachment point for the inferior belly of the omohyoid muscle, which attaches to the hyoid and is involved in motion of the tongue, larynx, and pharynx. So really, when you think about the muscles that attach to the scapula from an osteopathic perspective, you could trace almost every somatic dysfunction in the upper body and even potentially the pelvis to the scapula. So you can imagine in a 15 to 30 minute patient care appointment, the scapula becomes a really high yield muscle to treat because it is so connected to the rest of the body. So in terms of moving on to the actual treatment, it's actually really similar to a treatment that we learned in our first semester of medical school, which is the lateral recumbent scapulothoracic stretch. That's the treatment where a patient lies on their side in the lateral recumbent position, and the practitioner holds the scapula and places the patient's arm either over their shoulder or over their arm and kind of uses that as a lever to really get the scapula moving. Sometimes it can be a little bit difficult to get the patient to go on their side, depending on their mobility. And also, if you're doing a bunch of treatments where the patient is supine, it can be helpful to know how to treat the scapula from multiple positions. So in terms of the treatment that I'm going to talk about today, this involves the patient lying supine on their back, and the practitioner goes to the side of the patient and tucks their hands underneath their scapula, so the finger pads are actually along the medial border of the scapula, and the finger pads can kind of dig in between the scapula and the rib cage. The thumbs can then hook around the inferior angle of the scapula and the scapular spine, and this treatment position really provides a really firm hold of the scapula, allowing the practitioner to really move the scapula in every direction that can go, and that includes superior and inferior motion, lateral and medial motion, as well as circumferential motion, and like retracting and protracting as well. And what I really love about this positioning as well is that it allows the practitioner to employ a lot of different OMT treatment modalities. So this includes soft tissue, if one feels hypertonicity or other tissue texture changes where soft tissue like inhibition or kneading might be an appropriate treatment. It would be really easy to do that in that position. Additionally, while motion testing, maybe BLT or MFR would be a treatment that could be applicable for any given patient. So that's another treatment that can be employed as well in that position. And it really, from like the objective practitioner point of view, this treatment really allows to augment the range of motion of the scapula. And subjectively, from the patient point of view, from the patients that I treated, they really were able to tell or feel how much more motion they had in their scapula and upper extremity. And of course, as we learn from many scapular treatments, it's definitely a great idea to treat both sides. This is something that I did while treating my patients as well. And again, it's something that really can connect to so many different parts of the body that I highly recommend employing this treatment with patients that you have in the future. Thank you so much.